Ladies and gentlemen, I hope you enjoyed that insight into the curation of a fragrance by Ruth. And what I wanted to share with you is how that has come into my world and my space in my consulting room, and how that has influenced how I practice my facial injectables, with how patients benefit from the scent of one of Ruth's fragrances. My next speaker is a very, very dear friend of mine, one of my best friends, and I've had the pleasure of knowing her since 2006, when I was a plastic and surgical trainee in North Bristol NHS Trust. Miss Roba Khundkar is a consultant in plastic and reconstructive surgery, and she is senior clinical lecturer of global surgery. Roba and I grew a long way. I have been in theatre, I have watched her stitch, operate, and turn into one of the finest surgeons I have ever seen, both in the operating theatre as well as a trainer, an educator, and master of her craft. I'm so honored when I invited Roba to share with me, and now with you, things that she does both in the NHS and beyond. And for me, this was particularly important. As I have traded my scalpel to embrace a new way of my life in my new career in medical aesthetics, I never ever want to forget the importance and essence of what reconstructive plastic surgery is all about. And I'm so excited that the one person that is very dear to me, Miss Roba Khundkar, can share with you that world right here, right now, to you. Ladies and gentlemen, my best friend and consultant plastic and reconstructive surgeon, Miss Roba Khundkar. Roba, hello. So great to see you. How are you doing over there?
I'm great, thank you. How are you?
I'm good. I'm so happy that I get to see you like this. This is not how we normally see each other. So you look fabulous, as always.
As do you. Learning from you, Sharina.
Well, we have to do our best. Once upon a time, you and I, gosh, how long have I known you for, Roba? Since the 6th of February, 2006.
I love how you know the exact dates.
I think I even remember what we were wearing. We were plastic surgical trainees, North Bristol NHS Trust, Frenchay Hospital. We both started on the same day.
Yes.
And I knew that we'd be best friends ever since.
Are we?
Yeah.
We are.
Absolutely, we are. But look, Robert, I just want to say thank you so much for your time today and for being a part of our virtual event, all based around patient education. So thank you so much for joining us. And for me, what an absolute honor. You're not only my best friend, but you are a consultant plastic and reconstructive surgeon in the NHS, senior clinical lecturer in global surgery. And I'm so honored that, you have given us your time today to share your experience from a plastic and reconstructive part of view, but also from an education point of view. So yeah, how do you feel about joining us today?
Well, thank you for inviting me. I feel equally honored that you would actually think of inviting me, not just because I'm your best friend, but it's you've done so well. You've taken a slightly different direction to me, but you've done incredibly well. And I feel very, very honored. I've watched you progress and grow your organization, and it's been, and you've done it with integrity, which I've always admired. So I feel absolutely honored that you'd even asked me to join. And I've seen some amazing speakers that you've had on this platform before. So to actually join such a great platform is great for me, and not to mention really fun to do it with my best friend.
It's going to be amazing. Thank you, Robert, but also for your kind words. You've been a key part of aesthetics as in my journey. It had been a vision of mine. Well, actually, we talked about doing something together for a while. Back from 2006, we talked about this moment, didn't we? And I thought at that time we would be doing something together in the reconstructive point of view. And I guess we've both taken those different paths. I have watched you grow into this most amazing reconstructive surgeon, and now to watch you go even beyond the United Kingdom, to go international and to take your skill sets to that platform, as well as to educate other surgeons, other budding surgeons, other surgeons in other countries. I find so inspiring. I really want to give the opportunity to our patients and audience listening today to actually get a deeper understanding into your world, but from both sides.
I think we share one thing in common, Roba. Well, we share many things in common as well, in and outside of work. But one main thing is that I think both of us share that patient journey, that synergistic way in which we both operate to get that outcome, which is the result. And I always say to our patients, it's all about the results. I say that to my team, results that you can see, track, measure, and celebrate, both from a functional, but also from the aesthetic front. We both just do it maybe in slightly different ways. I have moved into a different directive. I have gone into the non-surgical arena, but my values are still the same. And you've taken it in that direction. So big congratulations to you, Roba.
No, thank you. You've been very kind with your words, and I think you're right. The outcomes all depend on understanding each other's journey, I think, and being able to communicate that with each other. And we, as you know, as part of our training, we try very hard to try and understand our patient's journey. I think sometimes maybe it would probably help if our patients could understand our journey a little bit as well. And I think I don't really get to share that very often. So thank you very much, and hopefully I can share a little bit of an insight into what I do, and it might help our audience who are listening in to get an understanding of what the journey is on this side.
That would be wonderful. So 2 sides to the coin here. So why don't we start? I think what I'd love to do today is we are actually going to watch a slide presentation by you, which is amazing. You're going to be covering things that you do as a plastic and reconstructive surgeon here in the United Kingdom. And we're going to have this wonderful opportunity to also see you educate at an international level and beyond as well. So I'm going to let you continue, and I'm going to step away from this, and the stage is all yours. Thank you to Zoom for enabling us to do this, Roba. I'm going to now pull out and let you share your slide deck, okay?
Great. Well, thank you once again. So I'm often asked what we do as plastic and reconstructive surgeons, and the simplest way of saying it is we make stuff. We make body parts for those of our patients who have lost a body part or have an altered body part usually from infection or trauma, burns or cancer. And what we try and do is restore form and function. So that's essentially what I do. And the question is, why do I do it? Or why did I choose to do this particular subspecialty? Well, I was one of those medical students who enjoyed everything at medical school, and I didn't really know what I wanted to do when I qualified as a new doctor until I heard this lady speak. And Oprah said that when it comes to choosing your specialty or your career, you need to do something that came as easily as breathing. And that really made me think, and I thought, oh, what comes naturally to me? And I thought, this is what comes naturally to me, making stuff. And Sharina, you know this, you've seen a lot of these things when we used to live together and work together. I love making stuff. My parents' house is full of completed and incomplete projects. And I've always been quite creative. So I thought, really, the only medical subspecialty that would allow me to foster this creativity would be plastic and reconstructive surgery. And the training in the UK is quite long. At 13 years after medical school, I became a consultant plastic surgeon. So that's actually 19 years of training to become a consultant plastic surgeon in the UK. And what I do now on a daily basis is I make stuff, I restore form and function for our patients. But I don't do that alone. None of this can be done alone. We put our patients first. Patient safety is of paramount importance. And we want to deliver a safe and high quality service to all of our patients. So we do them in teams. You know, I don't make stuff on my own. I don't reconstruct patients on our own. There's a massive team. And my particular area of interest is sarcoma surgery. And sarcoma is a type of rare cancer. And I'll come back to that in a minute. But let me introduce you to sarcomas. Sarcomas are a rare group of cancers, usually of bone, muscle, fat, nerve, blood vessels, and other tissues. And it's a very, very old disease. In fact, I came across a Canadian group of researchers who found an osteosarcoma, a bone sarcoma in a dinosaur that lived 77 million years ago. So we treat similar kind of tumours in humans. And this is the team I work in. It's the Bristol sarcoma team. Because they're rare cancers, we treat sarcomas in the UK in specialised units, and I'm part of the specialised Bristol sarcoma team. And all of the members in this team are specialised to treat this kind of rare tumour. So I work at Southmead Hospital that you can see on the top right-hand corner. And in the pictures here, there are some surgeons. There's Paul Wilson, pretty much in all of the pictures. He's one of the surgeons, one of the senior surgeons in the team. And I work with 2 other surgeons, Tom Wright and Tom Chapman. So the 4 of us make up the surgical side of the sarcoma team. We have nurses, specialised sarcoma nurses, Chris and Becky, who do an amazing job. They keep the team together. They liaise between patients and multiple teams, including ourselves. We have Jane, our sarcoma physiotherapist, on the top left-hand picture. We have oncologist Gareth and Paula, and Gareth actually leads the service. We have trainee surgeons who are learning the skill. And behind the scenes, we have people like our administrators, our secretaries, Julie and Debbie, who keep everything together. They coordinate the teams. And it's really important, and you know this really well, Sharina, you know, there is always a team of people behind the work you do who keep it all together. Otherwise, these things just don't work. And there's just a picture on the right hand showing, despite the lockdowns, we have continued with our sarcoma care all throughout. So what does a sarcoma actually look like? How would you know you have a sarcoma? Well, a sarcoma essentially presents as a lump. And most of the lumps I see are actually fatty lumps like this one. This person has a lump on their back. It's a fatty lump, also known as a lipoma, and it's a non-cancerous lump. And it just looks like this fatty lump when we take it out. The problem is, of course, when you come to see me, when I see you, I don't know if this lump is cancerous or not cancerous. And I need to take a history from you, examine you, and then make a decision. And sometimes I can't do it just on history and examination alone. I would need to do some tests. Sometimes when we do the test, we still don't know, and actually we do have to do some surgery and actually do a biopsy, which might be the whole thing or part of it, to find out what it is. So given that we can never really assume something's okay until we've done the full investigations, what I would say to any of you listening, if you have a lump or a bump, please do see your doctor, and see your doctor early. It's not to worry you, because actually the truth of the matter is most of the lumps and bumps that we will see are actually non-cancerous. But amongst those, there are a few people who will have a cancer, and it's really important that we pick it up early. So please do see your doctor early if you come across a lump or bump that you think, I don't remember having this before. So here are a sample of other lumps I see. So this is a lady who had a lump in her wrist. It was quite hard. It didn't really feel like a fatty lump, and she said it's been there for a few months now. So I took it out, and you can see it's got two little attachments around the sides, a bit almost like one of those Pandora's bracelet links. And it's actually a little tumour that's arisen from the muscle wall of a vein. It's called an angiolymyoma. It's entirely non-cancerous, but there was no way of us knowing that without taking it out. So I was pleased that she came to see me and had it taken out. Here are 2 other ones. They look big and they look a bit nasty, they look a bit horrible. We took those out on the assumption that they might be something concerning, but they are called pilometrixoma. They're non-cancerous as well. But again, we do need to investigate to make sure that they're nothing worrying. This is slightly different. This doesn't look particularly worrying. We're looking at, on the left-hand side, we're looking at someone's chest. You can see the nipple on the right-hand corner. And the tumour in the middle there is actually a sarcoma, a rare cancer related to the skin, even though it doesn't look like it's anything too much. So we did have to take it out. And when I took it out, there was quite a large hole. But luckily, I was able to cover that hole with some skin right next to it. And on the right-hand side of the picture, you can see the kind of scar, almost a Harry Potter scar that's left behind. But he didn't need anything too major. And Sharina, you'll remember, we learned to do these techniques together in our early days. And I'm still using those techniques that we learned. This is someone else who came up with a lump over his elbow. And this is a much larger, deeper lump. And sadly, because it was so big, we couldn't really just move some skin around from the arm to reconstruct it. But we were able to take the whole tumour out, and we had to take out a lot of skin, a lot of muscle. And about 10-15 years ago, this gentleman would have been offered an amputation for this kind of tumour. However, we now have much more advanced techniques. So we used a piece of skin and muscle from this gentleman's leg to reconstruct and microsurgically attach it to his elbow, which meant that he didn't lose his arm, and it's actually functioned very well, and he's very pleased with the results, and he's tumour-free. We sometimes take out some very, very large tumours. So this tumour was taken out of this lady's leg, including some bone. And actually, again, we managed to close up her leg and save her leg. She has some functional deficit, but she's an elderly lady who didn't want any reconstruction, and she's actually managing quite well with the aid of some splints. However, if she wanted anything else done, we can offer that to her in the future. And we have to always respect what our patients want. It's not an one size fits all. We tailor everything to what our patients' needs are in terms of form and function. And this last slide I'll show you regarding cancers is someone who had a Ewing sarcoma. It's a bone tumour of this gentleman's thumb. He actually has fairly good function in this hand, and with what's left of the thumb, he can actually grip. It's his non-dominant hand, and he actually said he didn't want a reconstruction. And again, that's entirely his choice. And in fact, he had this tumour I think it was almost 20 years ago, and he's had no recurrence of his tumour because it was a nice, clean surgery to treat him. Some of our patients will want it, especially if it's of the dominant hand, because you can't really use your hand if you don't have a functioning thumb, in which case we would have looked at options of reconstructing that thumb, often with a toe. And that's a fairly common reconstruction. Again, Sheena, you'll remember we did some of these when we were still training together. So at this point, I'll stop talking about the cancer work I do, and I'll move on to the other part that Sheena alluded towards, which is the education and global health work I do. And now that I'm fully trained, I thought it's taken me so long to train. I really want to share this. And I do a lot of teaching and training in the UK, but I also wanted to offer that, the skills I have, and share it with colleagues in other places where there aren't many plastic surgeons around. So now what I do is I teach reconstructive surgical skills to trainees in other parts of the world. And actually, it's really important to understand that the burden of disease for things like infection, burns, trauma, cancer that I treat, much higher in low and middle income countries compared to the UK for a whole variety of reasons. So the need for having fully qualified, specialised surgeons who can treat this is really, really huge. And I have been exposed to a little bit of global surgery, and I've been exposed to the world of inequity within global health as a child when my parents had moved around a lot. And as I grew up, I became more and more interested in it. And then recently I found out, quite shockingly, that 5 billion people in the world, that's 5 of every 7 of us, have not got access to surgical care worldwide. And when we're talking about surgical care and access, we're not talking about access to surgical care such as facelifts or rhinoplasties or hip replacements. We're really talking about life-saving urgent operations. For example, if you're in a car accident, or you were in a burning house, or you had cancer, these are life-saving operations. 5 billion people in the world have no access to essential surgical care if they needed it. So it really made me think that I really want to share my skills. And this is a map showing where this lack of access is. So the darkest red bits are where the population has no access to surgery. So that's mainly sub-Saharan Africans and Southeast Asia. The light pink ones are the areas where we have full access to surgery. And you can see it's quite unevenly distributed across the world. And again, just to put into context, more people worldwide die from road traffic accidents than HIV, TB and malaria combined. So I feel really strongly that we need to improve surgical services worldwide. And often people talk about the fact that it's really not possible because surgery is expensive. In low income countries, we really can't afford to expand surgical services. And that's true. And we've got studies looking at this. And if we wanted to get the whole world up to a set standard of basic surgical care, we think it would cost us $350 billion, which is a huge amount. However, we've also looked at the figures of the cost of not doing it in terms of losses, and that actually comes to $12 trillion worldwide. So we really, really can't afford to financially not scale up surgical services. So that's where my role comes in. I feel like I need to contribute towards expanding surgical services. So I'll come back to plastic surgeon training. So this is a research project I did with one of my students looking at the number of registered trained plastic surgeons in East Central and Southern Africa. And this is really, I'm putting these figures here just to give a little bit of context as to what we really mean by not having enough surgeons worldwide. So if you look on the names of the countries, from Burundi to Botswana, there are no plastic surgeons who are fully trained or specialised. to treat the population. Zambia has 1, Rwanda 1, Malawi 3, Zimbabwe 3, Mozambique 3, Kenya 6, and Uganda 7. And in the UK, there are 897 plastic surgeons. In the US, there are more than 8,000. So you can see the real difference. You know, we're talking about huge magnitudes of difference between the services in the context that these countries have much larger burdens of disease. And, you know, for example, Malawi's got 3 plastic surgeons, which means for every 6 million people, there's only 1 plastic surgeon. So for me, if I can train another one, you know, then that's 4 plastic surgeons in that country, and it really makes a huge difference. So I got involved with helping with teaching and training and examining for the College of Surgeons for East, Central and Southern Africa. It's a huge organisation crossing 17 countries, and they're training surgeons to treat 500 million people. And I'm only playing a small part by providing a bit of support, but I think together we can really make a difference. And here's me examining last year in Uganda, where they had their official, just like in the UK, I had to go through an end of training exams called the FRCS. In Africa, they go to the FCS, and there's internal board of examiners all from Africa, and there are a few externals. I'm one of the externals providing a bit of support. And here are some CASEXA graduates. I'm very proud to see these plastic surgeons. They were very highly trained. It was a real honour being able to examine them, and they are adding to that very small pool of surgeons in Africa, but I feel honoured that I've been able to help with their training. And I've also been involved in the training of the surgeons. So an organisation called Second Chance provide some of the plastic surgery training for CASEXA, and we run workshops, lectures, and operating for all the trainees who are about to sit their exams. And you can see I'm here in Zambia. I'm helping some of the trainees operate. I'm not doing any of the operating. We supervise them and teach them to operate on the types of patients they'll have to do on their own fairly soon. And this has been a real honour being part of this training programme. And on the left here, you can see 3 trainees, Francois, Neil and Ian. They're from Rwanda, so they're going to add to the existing 3 who are already there, so there'll be 6. And on the right, we've got Francois here again, and Dorothy, who's from Uganda. And I try and support all of these trainees through mentorship. So it's not just the clinical training I try and support. I try and support their research and personal development, just the way I try and support my trainees in the UK. I think everyone deserves to be treated equally, and I try and teach them all in the same way. So just a few words on what's actually happening to the world of global surgery with conflict and COVID. And obviously you can imagine this is what I've told you pre-COVID, and it's already quite difficult situations that we have to deal with, and COVID has just made all of that worse. And that's where my work, my research training, and advocacy work with Oxford University Global Surgery work comes in. We are attempting to look into a lot of the effects of COVID, and here's one of the studies that's just been accepted in BMJ Global Health Journal. This is a global study we did with our collaborators all around the world, looking at the number of healthcare workers who have died and been infected with COVID worldwide. And as far as you can see, this is the first study that's been done to look at it and been published. And you know, the study was born out of concern and safety for our frontline colleagues who are keeping us safe. And it is really sad and upsetting to lose a colleague anywhere in the world. But as you can imagine, losing a healthcare worker in a low-income country when you only have a few healthcare workers has a greater impact on the population than losing someone in a high-income country. So we're looking into more of this kind of research to see how can we change things. And just another line just saying it's not just abroad that I work. A lot of the work is done within the UK, because what I want to do is advocacy work, trying to encourage more of our doctors to get involved with global surgery education, more of our health professionals, and actually people who are not health professionals, anybody's interested, because it's such a large problem that we need to tackle. We need everybody's involvement. So I do a lot of advocacy work, including with trainees. So I'll stop there because I think that gives you a little bit of a flavour of what I do. If anybody has any more questions, I'd be happy to be contacted on these on Twitter or Insta or email. So back to you, Sharina.
Wow, goodness, Roba, I have to say, I'm pretty confident. In fact, I'm 100% confident if you were doing this live in front of an audience, the questions that would be coming through would be tremendous. And I've written down a gazillion questions right in front of me as well. And I fairly know what you're talking about, which, you know, is just because of the strength that we've worked together. But you have shared so much with me even, and I thought I knew you very well. But you've shared so much with me. And first and foremost, I want to thank you for that amazing presentation. Just giving an insight into your world as a consultant plastic and reconstructive surgeon from the sarcoma point of view. You know, your patients are very lucky to have you, and your skill set. You know, I've watched you just grow into this tremendous surgeon. I have watched every stitch you take. I can say that. Wholeheartedly.
Can I stop you there, Sharina? Thank you very much. Those are very kind words. But every time I stitch, I do think of you, because you were a few months ahead of me in your training. And when I arrived, I didn't even know how to put a stitch in. And I remember you actually taught me all of those techniques. Some of the techniques I showed, you taught me how to do all of those. My first stitches, just didn't know anything, actually. I was a day one plastic surgery trainee, and I'm, you know, forever grateful for you for teaching me that.
Anytime. It was my pleasure. Hey, you got me speechless now. I'm going to continue. So,
Carry on.
this is wonderful. Your skill set from a constructive point of view is tremendous. Watch you become a microvascular surgeon as well, and to do that kind of surgery is phenomenal. But I'd like to congratulate you on a number of things. From the educating the trainees, from improving global surgery education for other trainees like ourselves, right? I remember what it was like in 2006, and for you to be able to share this now with trainees that are upcoming and to beyond, I think is wonderful on an international level. Congratulations on your publication as well.
Thank you, Sharina. You've been very supportive all the way through.
Well, I had nothing to do with that publication. I have watched you in the last year go to Gaza, Rwanda, Uganda, you know, all these travels that you did on your own initiative together with your group in Oxford and beyond have been tremendous. But to see it coming into fruition, you didn't keep quiet during this time during COVID and all the lockdowns. You put that and you channeled all of that knowledge with your international teams into a publication. So well done to all of you. And also congratulations on your work on COSEXA, you know, the contribution to helping their training as well. And look at them now, they are able to deliver better access.
Exactly, that's the whole point. And you know, Sharina, even though we say it was 16 years ago or whatever that we started training, but actually doesn't feel that long ago. And you know, we still remember those days when we started and we didn't feel like we knew what we were doing, and we were so grateful every time someone actually took the time to teach us and train us and show what the right thing is. And it is still very, I'm sure you remember it really well as well. So, you know, I'm really keen to, now that I've completed, to return that in the UK and elsewhere.
True, it goes full circle around, you know. And on that note, I'd like to take the opportunity to thank all our trainers that we had during our time in Bristol. But I've got a few questions for you, okay? So talk about sarcoma, and you showed some fantastic slides there and great advice for the patient about if you run short, just ask your doctor. Do you mind how fast growing these types of, you know, tumors are?
Well, actually, you know, there's a whole range. Some can be there for many, many years. So if you've got a lump that's been there for 20 years, likelihood is that there's nothing to be worried about. However, something that's been there for 20 years can suddenly, you know, develop a few little changes in there. And often we have patients say, well, I've had it for 10 years, but suddenly it just feels a bit bigger. And if you think it's bigger, you're probably right, actually. And there are some that have not been there and they just appear within weeks. And those are the ones we do worry about. But I think if you've got a lump, just go and see a doctor. There is no reason. And actually, I say this with real concern because especially during COVID, a lot of people have not been presenting to their doctors. And we know that for all cancer care that, you know, everybody's been kind of going, oh, I'll just go a bit later. But actually, cancer care is continuing. So if you have a concern, do get in touch.
Go get it checked out, absolutely. And you showed some fantastic before and afters of, you know, your wounds being closed and the type of reconstructions you've done. First, there was the primary closure, which is remove the tumor and then straight away close. Can you tell us a little bit about the other types of reconstructions you've done, like the other flap reconstructions?
Okay, so one of the ones I didn't show, which is a very common one, is that when we take a tumor out and there's a hole, we take a shaving of skin from the thigh usually, or somewhere else, and it's called a skin graft. And it's just a little thin shaving. that you put on to cover the hole. But sometimes some defects are not suitable for that shaving. And you remember this, Sharina, you did loads of these. So one of the ones I've shown is called a local flap. So that's the one where I showed you is on the chest, and I moved a little bit of the normal skin around, and you ended up with a Harry Potter style scar. So that's called a local flap, and there are lots of varieties of that where you can just move a little bit of normal skin from around where you've taken the tumour. And that's quite nice to do, and it's a good colour match because it's from the same place and it's good texture. So that's one. And then the other one, which is a little bit more complex, is what we called a free flap or a microvascular reconstruction. That's when you can't, like I said, the elbow guy, you can't really move enough because you've got taken a huge, and the defect was absolutely massive and included skin and muscle and bone and all sorts. So you can't really move a bit of skin around. So you then have to look at another part of the body, and this is one of the things I specialise in, making another body part, making, returning form and function. So we look at what spare bits we have in the body, and quite often we will take some skin and muscle from the leg with its blood supply, and then we have these massive microscopes that we bring over when we're operating, and we reconnect the blood vessels to this gentleman's elbow so that that bit of skin and muscle can stay alive. And that's called a free flap, a microvascular reconstruction. And that's what's really changed the world of reconstructions, because we've moved on from doing amputations to actually being able to salvage limbs for people. So that's really what I really like doing. But actually, we don't do it if it's a fairly complex operation. But if we can get over with something much simpler, we do what's right for our patients, essentially.
Absolutely. Thank you for consolidating that so well. And that picture that you showed of the lady that could have lost her leg potentially, and you said that, so.
And again, she's an example of a lady who lives alone, and she was so worried about this lump that was growing in her leg. She was too worried to even see someone, and just hid it from her son, hid it from everybody, and just stayed there, and it grew and grew and grew. But she could have presented much earlier. So we do need, we were able to treat her, but sometimes it's a little bit too late.
Well, you basically summarized that very nicely, really, that, we don't, either yourself or myself, there's never a one size fits all. Everything is
no, exactly.
Tailored, bespoke, customized, whatever word you want to use.
Yeah.
Suit that patient's need. And it all boils down to one thing, the consultation process, right?
And you're right. I think that's what one thing we really do share. And I think partly probably because we train together and we start off with the same principles. It doesn't matter what we're doing. It is about the patient. It's about the patient's outcomes. And it's actually about tailoring the skills we have to what they need. And regardless of whether you're doing aesthetic work or reconstruction, the principles are still the same.
Absolutely. The consultation, the diagnostics, the investigation, and creating a treatment plan, a treatment strategy, and then implementing that, and then seeing that final outcome, which is the best. We both want
and the final outcome is about the whole patient. It's not just about me looking at the elbow, it's about the whole patient. And then I'll tell you a story which really will summarize it. I saw a really lovely gentleman who came to me with a tumor of his arm, just here in the biceps. He looked a bit like Popeye, had this little lump kind of coming out. He was in his early 70s. And he said, I need this treated. And I said, yes, it's actually sadly a tumor. I need to take it out. And, sadly, you might have a little bit of loss of function possibly. And he said to me, so I was thinking about his loss of function, but actually that wasn't what he was worried about. His aim was, I'm sure he won't mind me telling me this, he said to me his grandson had been diagnosed with a childhood tumor who was only 8. And he said to me, all I want you to do, doctor, is treat me for long enough so I can stay alive to have a drink with my grandson when he's 18. What happens after that doesn't matter. So that was his aim. And it's really important we find out what our patients' aims are.
There we go. That's a beautiful story. Thank you so much. And I'm sure you're going to give him exactly that. Or you're
He's doing very well. He's very good. I'm hoping to get him to his drink with his grandson, who is now 9.
And that's what it's about. It's a result that we can see, track, measure, and ultimately celebrate with our patients.
Yeah, exactly.
Satisfaction at the end of the day. But again, I want to ask you about your teaching and training. I love the story that you just said earlier about Oprah. Do you know you've never told me that?
Have I not?
You just never have.
I don't think you've ever actually asked me why I did it, because we were both in it together. So I don't think we actually ever asked each other why we were doing it.
No, I think we were just too busy having so much fun together,
Yeah, I remember.
You talked about your passion, the Oprah. It makes so much sense. And, feeling like you wanted to use the passion to give back, to contribute.
Yeah, I mean, you know, when you spend 19 years training, you kind of feel like you need to maximize this training and share that training with others as well.
Well, you say 19 years, you're going to be giving our ages away, Roba. I think the audience are going to agree. You look extremely, extremely youthful.
Thank you.
Look, you know, and you summarized you summarized so many things that I think we work synergistically, you know, to the same values. We don't do this alone. We do this as part of a team.
Yeah. Yeah.
At the moment, but same principles.
Yeah. And I think that's really important, because I think, you know, we grew up in a kind of environment where there was a lot of kind of the doctor is an individual who treats the patient, but actually we've moved on for that. We know we're much better at teams. We know we're safer at teams. And, you know, I can't do any of those reconstructions on my own. I've trained, yes, but we need the whole team. You know, whether you're doing your aesthetic work or whether I'm doing reconstructive, we need the whole team together. We need colleagues. We need, you know, and the patients are central to that team, and we do it all together in discussion with our patients.
Absolutely, we say the same thing, patient-centric, us around that, and you know, that's how we move towards the common goal. But look, Roba, you know, I want to thank you so much for your time. I know that you're championing what you're doing locally here in the United Kingdom and also on a global scale as well. And I'm just really proud that I get to watch from afar and just continue to watch your star rise internationally. So big thank you.
I think you underestimate what you do. You're not just watching, you've been supported all the way through. So thank you so much for all your support for all these years. And you know very well, it hasn't always been easy. You've been supportive, and I've been absolutely so proud watching you grow and see what you're doing. And I've been learning from you as well. So thank you. And thank you once again for inviting me.
The force be with us. But one last thing, I'd love to end on a word of positivity. Anything you'd like to share with our audience as we are in this new world?
Yeah, I think what I've learned with all of the work I've done, especially during COVID, is that people have come together much more easily. You know, the last study I showed you was actually a global collaborative of 63 authors across 16 countries. And people come together in a way that we've never managed to do before. So I think that's a real positive. And I think that is what's going to get us through these difficult times. I think that's a great positive. And what I really want to see is that we get together with our patient groups as well. And we actually come up with solutions for our own healthcare systems together with patients, with collaborators nationally, internationally. And I think that is what's going to come out of this. And I think that I'm really hopeful for that.
Thank you. And tech is giving us the opportunity to do even this. I can't see you know, in touch anymore for a while anyway, but I can certainly do this with you. So, Roba, thank you so much. Have a wonderful
Thank you.
I'll see you again soon. Love you.
See you soon. Bye. Love you too.